A very big welcome to everybody who has joined us today for this webinar. We have two fantastic speakers who are going to discuss the topic of SUDEP in a fair bit of detail. So let me introduce our two speakers. They're going to share the next talk rather than just divide it in half, so they'll be alternating. And we have starting Dr. Daniel Friedman from NYU Grossman School of Medicine in New York, and Dr. Elizabeth Donner from Hospital for Sick Children in Toronto, Canada. Both have done a lot of research and have published and spoken a lot about the subject. So I think we will have an excellent presentation. Dan, over to you.
So welcome everybody, and thank you for joining us. Here are disclosures. So in today's talk, we're gonna cover a lot of ground and hopefully quickly enough that we leave time for questions and answers. So briefly, we're going to talk about epilepsy mortality, and then specifically about SUDEP definitions and epidemiology, risk factors, touch a bit about mechanisms and differences between children and adults, as well as then strategies for SUDEP prevention and special considerations across the lifespan. So by way of introduction, most people with epilepsy have a normal life, normal lifespan, but epilepsy is a spectrum condition and can be serious in some cases. And if you take all people with epilepsy, there's a 1.6 to 3-fold increase in mortality compared to the general population. Many of those premature deaths are due to the underlying cause of epilepsy, whether it be brain tumors or neurodegenerative conditions or other conditions that affect the lifespan. But even people with epilepsy of unknown cause have increased mortality compared to the general population and a reduced life expectancy. So why do people with epilepsy die early? Well, sometimes it's the adverse effects of treatment, somewhat rare, but there can be life-threatening reactions to medications or surgeries and things like that. There's also a growing body of evidence that some of our seizure medicines themselves can increase the risk for cardiovascular disease late in life and cause premature mortality. Some of the comorbidities that some people with epilepsy experience can lead to premature death as well. People with epilepsy have higher rates of suicide, substance abuse, and being the victim of assaults related to underlying psychiatric comorbidities. But a lot of the causes of early death in people with epilepsy are related to the seizures themselves. People can have prolonged seizures called status epilepticus, and that could lead to hospitalization and death. People can have accidents as the consequence of their seizures and drownings as well. Sometimes seizures can lead to aspiration, some of the stomach contents going into the lungs, and pneumonia and complications from that. But about a third to a half of all seizure-related deaths in people with epilepsy are due to sudden unexpected death in epilepsy or SUDEP. So switch it over to Elizabeth. Talk.
Good morning, everybody, and thanks, Dan. First off, next slide. I think I'll pause for a sec and just comment on that. We know this is a difficult topic. And so for people who are living with epilepsy or caregivers of people with epilepsy, we just want to acknowledge it's difficult to talk about epilepsy-related mortality or deaths. Next slide. And it's kind of like the elephant in the room, if you're familiar with that expression, which means there's a big thing in the room and nobody talks about it, even though everybody notices it. And so what we find is that it's best to actually acknowledge the elephant in the room. And Dan and I both, I think, feel pretty passionate about that. Next slide. And we know that people with epilepsy actually want to know more about their risk. So in surveys, up to 62% of adults with epilepsy and up to 94% of caregivers of people with epilepsy are worried that the person with epilepsy may die related to their epilepsy or seizures. And actually, an interesting study where they looked at the number of Google searches for the terms epilepsy and SUDEP showed that from 2004 to 2013, which is still obviously 10 years ago, there was an increase in Google searches of 5,000% just looking for that term. We know that 91% of UK parents surveyed wanted to know more about SUDEP. And from our own data through the North American SUDEP Registry, 72% of people who had lost a loved one wished SUDEP had been discussed with them. Next slide. So with that background, we want to remind any practitioners, any healthcare providers, or epilepsy advocates on the webinar today or watching that, in fact, the best source of information for people living with epilepsy is you and experts rather than what they might find on the internet. So let's talk a little bit more about it. So what is SUDEP? So SUDEP stands for sudden unexpected death in epilepsy. And it's, as it sounds, it's the sudden and unexpected death in a person living with epilepsy. It excludes deaths due to trauma, drowning, and status epilepticus. And ideally, an autopsy or postmortem examination does not find a cause of death, and that's when we can call it SUDEP. Now, mainly for research and trying to keep track of these deaths, we've recognized that not everybody who dies with epilepsy has an autopsy to investigate the cause of death. So we use terms like probable SUDEP when no autopsy was performed, or in cases where the autopsy is unclear, we use terms like possible SUDEP when there is limited information, or SUDEP plus when there is another condition that may have contributed, and it's actually kind of hard to decide whether it was SUDEP or related to a contributing disorder. A couple points that are important. There doesn't need to be evidence of a seizure for SUDEP to be assigned as a category. And this idea that really SUDEP is just a category of deaths with defined criteria, and it does not tell us why the death has occurred. Next slide. So how often does SUDEP occur? Next. Well, this graphic depicts that SUDEP affects about one person living with epilepsy out of 1,000 people per year. Those are called patient years. So we say one in 1,000 patient years. And that means if 1,000 people are living with epilepsy for 1 year, one of them will die of SUDEP. The next year, put one more in that 1,000, and one will die of SUDEP. Next slide, Dan. And some of the ways that these numbers were kind of come up with, and I'm going to talk about this work a couple times in my contribution today, is through some work that was done with the American Academy of Neurology and the American Epilepsy Society. That said, it was an international panel with quite a few of us participating, trying to develop some guidelines around SUDEP for people treating people with epilepsy. And as part of that work, we asked two pretty specific questions. One, what is the incidence? And two, what are the risk factors? Next slide. So when we did that work, we looked at all the existing studies to date at that time and computed, kind of put it all together, and then computed the rates of SUDEP overall in all people living with epilepsy, the rates in childhood and the rates in adulthood. And you can see there that the overall rate of SUDEP was about 0.6 per 1,000 people per year. The rate in childhood that was computed at the time was 0.2 per 1,000 per year, and the rate in adulthood was 1 per 1,000 per year. And I just want to acknowledge that since this work has been done, next slide, there's been further work to demonstrate that SUDEP rates are probably similar across the lifespan. And the reason it looked like it was lower in childhood was due really to difficulties with defining and finding cases of SUDEP in children. So work that came out of Sweden from Torbjörn Thompson's group, and work that came out of Ontario, Canada, from my own lab, both demonstrated that rates in children are pretty consistent in about 1 per 1,000 per year, same as adults. So right now we feel pretty confident to say that the rate is 1 in 1,000 per year. Next slide. The other thing we looked at with the American Academy of Neurology group was what factors increase the risk of SUDEP. Next. And if there was one take home, I'll steal the take home message, Dan. If there was one take home message today, the most important thing I want people to take away is that generalized tonic-clonic seizures are the most important predictor for SUDEP. And the frequency of GTCs, what I'll call GTCs, or generalized tonic-clonic seizures, and those are those like whole body shaking seizures or generalized convulsions, that the more GTCs a person with epilepsy has per year, the higher their risk of SUDEP. So if you look at this, I can't actually kind of point to things, I don't think, because Dan is leading. Or maybe I don't know. But yeah, if you look at just having a history of having generalized tonic-clonic seizures increases the chance of SUDEP 10 times. And if you look at having, for example, 1 to 2 per year, increases in the last year, increases at 20 times. But if you go down a couple lines, having more than 10 a year increases the risk of SUDEP 26 times. So if we can do something to reduce the frequency of generalized tonic-clonic seizures, we're going to reduce the risk of SUDEP. Further to that, not being seizure-free at all of any kind of seizure for the last 5 years also increases risk, as does not trying new treatments when seizures are refractory. And I'll talk a little bit more about that next. Thank you, Dan. I also want to point out that nocturnal seizures, which means having seizures overnight, is a risk factor. And that's kind of not surprising because we know that the majority of SUDEP deaths occur from sleep when people are sleeping, be it nighttime sleeping or having a sleep during the day. And so it's not surprising to learn that having generalized tonic-clonic seizures at night also increases the risk about 8 to 9-fold. Next. Some newer data that's come out in the last few years that's very important, I think, and interesting, demonstrates that even though frequent generalized tonic-clonic seizures puts people at risk, and especially having them at night puts people at risk, in fact, there are things that can be done in the home living situation that can reduce that risk. And that's what I mean when I say home environment modifies risk. So some nocturnal supervision, which means somebody looking in on a person through the night, or sharing a home with someone, or sharing a room, a bedroom with someone, actually reduces risk, as does using a nocturnal listening device. And Dan's going to talk a little bit more about seizure detection, but here a nocturnal listening device is really just like a baby monitor, do result in modest SUDEP risk reduction. And that effect is amplified when you combine it with the frequency of generalized tonic-clonic seizures. So when they looked at a person having 4 or more generalized tonic-clonic seizures in the last year, living alone, they had an 82 times increased risk of SUDEP. But if they shared a household, that reduced to 34 times. And if they shared a bedroom, 20 times increased risk. So a really dramatic risk reduction in people who share a home or share a bedroom. Next slide. I also want to address whether using medications or certain medications for epilepsy change the risk of SUDEP. There was some early work, trying to think when that was, probably about 2010, so over 10 years ago, that initially suggested that polytherapy, taking multiple medications for epilepsy, may increase risk. And this is the reason why I really like to address that, because if you read that old paper, you might go away thinking that. But they actually re-looked at that data, because obviously, if people are taking a lot of meds for their seizures, probably they're having a lot of seizures. And when they considered or worked into the model how many seizures people were having, they realized that, in fact, it wasn't the number of drugs, it was actually the frequency of seizures or how many seizures people were having. So, in fact, when you consider the frequency of GTCs, and this is the study where they kind of re-looked at it to kind of examine that, they demonstrated very clearly that there is no increased risk associated with any single medicine. And there is no increased risk with being on a single drug versus multiple drugs. So it doesn't appear that the number of drugs you're on or any specific drug increases your risk. And in fact, in contrast, next slide, please, there's really nice data to show that SUDEP rates are lower in people who are prescribed an effective dose of another drug to try and control their seizures. So this is great work that came out of Philippe Rivelin's work and his colleagues, where they looked at a whole bunch of randomized controlled trials. These are pharmaceutical industry sponsored trials where they're investigating new medications for epilepsy, and people are randomized to either receive a new medicine on top of their existing medicines or to get a placebo or a tiny dose of a medicine. And what they found is that in the people who were given the new medicine, and it didn't matter which medicine, all the new medicines, if you were trying a new medicine at a right dose, at an effective dose, that SUDEP risk was reduced. So this is an important message for us that even when people have refractory or difficult to control seizures, we should keep trying new treatments, and that not only to try and improve all the things that get better when we have less seizures, but also to reduce SUDEP risk. Next slide. I think it's back to you, Dan.
So now we're going to briefly talk about potential mechanisms of SUDEP. And it's important to note that that we don't fully understand why SUDEP happens, and in SUDEP may not be one thing, but different things in different people. But we do know some things, mostly about studying the unfortunate situation where SUDEP happens in the hospital. And so about 90% of SUDEP that is witnessed not only in the hospital, but out in the world, out in the community, occurs after a clear seizure. And in those rare cases where SUDEP happens in a hospital, all the SUDEPs have occurred following seizures. And most of those seizures have been tonic-clonic seizures. And when we look at autopsy series of people who had died from presumed SUDEP, there is usually some evidence of a recent seizure, such as a tongue bite, or the person was found in an unusual position. So seizures seem to be key to at least some of the many of the SUDEP, and so it's important to think about what the effects of seizures, especially tonic-clonic seizures, are on the breathing and heart function, blood pressure control in the body. And we do know from studies both in patients as well as in animal models of SUDEP that seizures can lead to something called central apnea, which is a loss of the sort of vegetative, the brainstem drivers of breathing. It can also sometimes cause the vocal cords to spasm and obstruct the ability of the patient to breathe. SUDEP can also, seizures can also cause a prolonged coma after the seizure stops. And in the right setting, that coma can lead to a loss of protective reflexes. So if any of us turn over onto our face into the pillow at night, the level of carbon dioxide in our bloodstream would rise, and that would trigger us to wake up and change positions. But if you are in a seizure-induced coma, those protective reflexes may be absent. And seizures have also been shown to cause heart arrhythmias and autonomic dysfunction, ability of the blood pressure of the body to regulate blood pressure correctly, and reflexes in too fast or too slow heart rates. And so the thought is that all these cardiopulmonary effects of seizures in the right place, in the right time, and in the right environment can cause sudden death in some people. Next to Elizabeth.
Thanks. Next slide. So we thought it would be important to talk just briefly about some of what we know about mortality in what we consider to be the rarer epilepsies, more rare epilepsies. So limited data suggests that SUDEP is more common in some childhood onset epilepsies, specifically the developmental epileptic encephalopathies, which are often attributed to single gene disorders and often attributed to genes that affect ion channels in the brain. These are the channels in our cells, the spaces in our cells that let things like sodium and potassium and calcium move in and out of the cells. And when you have a disruption in that process, you can get a pretty significant epilepsy that is often accompanied by drug-resistant seizures, as well as developmental disabilities. And the most evidence around SUDEP and these rare childhood onset epilepsies comes from what we know about Dravet syndrome. Dravet syndrome, it's also called severe myoclonic epilepsy of infancy, is a seizure disorder and developmental disorder that starts in the first year of life with quite frequent seizures and can result in pretty difficult to control seizures. And it's related to a sodium channel mutation in a gene that encodes for sodium channels in the brain. And studies from both Cooper and Shmuley have shown that SUDEP rates in people with Dravet appear to be higher than in the general epilepsy population. So in this study, they looked at 100 consecutive patients with Dravet and found that the overall mortality rate was quite high, and the SUDEP mortality rate in Dravet was about 9 per 1,000 people per year, which is 9 times higher than the general 1 in 1,000 I was talking about before, but is actually pretty consistent with some of the studies that have looked at people with really difficult to control seizures. Next slide. So since Dan was talking about mechanisms and what happens and why people, what's happening behind the scenes with SUDEP, I wanted to kind of think for a minute about why SUDEP would be more common in Dravet syndrome as an example of one of these difficult to control channel epilepsies or developmental epileptic encephalopathies, and just kind of break that down into 2 possibilities. One of the reasons could be because people with Dravet have a lot of the known SUDEP risk factors. For example, the frequency of generalized tonic-clonic seizures and the early age of epilepsy onset, comorbid cognitive impairment. But in fact, when we look at this, a Japanese group looked at 59 Dravet deaths and found that seizure severity did not seem to be a risk factor for mortality in that group. But there is kind of limited data about this. So it could be that the reason that SUDEP is more common in Dravet is just related to what we already know about Dravet risk factors. But some of the things that go against that is also the very early age of death in the Dravet group. So it could also be that these genetic mutations that we see in people with Dravet as an example of these channel disorders could also be present in the heart and the brain at the same time, and that what's affecting the brain to make seizures could be affecting the heart to increase the risk of a sudden death. And there's a little bit of evidence from animal models that that cardiac dysfunction may be present in people with Dravet and some other developmental epileptic encephalopathies. And there's some human data suggesting that heart rate variability is impaired in Dravet syndrome. And we know that people with impaired heart rate variability also can have an increased risk of death, even if they don't have epilepsy. So that was just a little bit of an aside for us to think about a little more what some of the factors could be behind what's happening with SUDEP. Dan.
So in the next part of the talk, we'll talk about different strategies to reduce SUDEP risk. And we'll start out with probably the most effective, but a strategy that has been shown in the literature, which is seizure control. And as Elizabeth mentioned, that patients who were randomized to effective medication had a 7-fold lower risk of SUDEP compared to those randomized placebo in clinical trials. We know that if epilepsy surgery is successful, it not only improves seizures, but it normalizes mortality rates. So people who are seizure-free after epilepsy surgery have mortality rates that are comparable to the general population who don't have epilepsy. And there's evidence as well that other treatments that improve seizure control, like vagus nerve stimulation or responsive neurostimulation, have SUDEP rates that are lower than expected for that kind of treatment-resistant population. But seizure control also is important in terms of avoiding what I term as avoidable seizures. So these are people who, in general, have well-controlled seizures, but for other factors besides their epilepsy, may have occasional seizures, and those seizures are a roll of the dice that may, in rare circumstances, lead to SUDEP. So we know that people who have lower adherence, who aren't taking the medications as prescribed, has been associated with higher rates of mortality and SUDEP, and strategies to improve adherence can reduce SUDEP risk in some patients. And we have to remember that the majority of issues with adherence in people with epilepsy are unintentional, meaning that they're related to forgetfulness which is a big problem if you have to take multiple medications in a day and you have also memory issues related to your epilepsy. There also are intentional issues with not taking medications as prescribed that we as neurologists should be aware of and discuss with our patients. And that's issues related to the cost of medications, to unpleasant side effects of the medications that cause people to not want to take their medications. Certainly other factors related to lifestyle that make more seizures more likely may also be associated with increased SUDEP risk. So we know that in some people, alcohol use can provoke seizures, and SUDEP cases tend to have higher rates of alcohol and substance abuse in some series. There's also some evidence that SUDEP is slightly more likely to occur on weekends and holidays when people may be cutting loose. And so strategies to limit alcohol use in people with epilepsy, and especially with brittle seizures that can occur so rarely, but in these contexts, is important. And then finally, appropriately identifying and treating seizure clusters and repeated seizures that come back to back, with rescue medication may be a good strategy as well. We do know that people who have a history of seizure clusters have higher mortality rates. Other strategies that have been proposed, although not well sort of tested, is the use of seizure alerting devices for SUDEP prevention. Elizabeth already mentioned that people who share a room or share a household with somebody have a lower rate of SUDEP. And the thought is that it is because there's somebody around to recognize that a seizure is taking place and deliver some sort of intervention, whether it's to roll somebody on their side, stimulate them to start breathing, or wake up more sooner after an ictal coma, may help. And the idea is, well, not everybody has a roommate or a bed partner. And if you have some sort of sensor that can detect that a seizure is taking place and alert a caregiver, they could provide that intervention. And there is some evidence that intervention can reduce risk in the unfortunate cases of SUDEP that happened in the epilepsy monitoring units. The patients that ultimately died from SUDEP, intervention was late, happened 13 minutes after the seizure had occurred, and those people subsequently died. But there were other cases where the seizure was recognized early, and they survived, even though they had a very short degree of sort of cardiac arrest because resuscitation was started early. And in terms of sensors for epilepsy, there are several on the market around the world. I'm not going to go through all of them, but I'll highlight different kinds. But probably the most popular and type of sensor that is commercially available are wearable sensors. So these are sensors that are worn on the wrist or the arm that detect seizure-related movements, convulsive activity, as well as other types of physiologic signals, such as autonomic function or heart rate, that help tune the detection algorithms. And so there are armbands, there are wristbands, there are apps that can run on commercial smartwatches as well. And these devices are pretty accurate for detecting and alerting for tonic-clonic seizures. And depending on the study and the device, about 80 to 100% of tonic-clonic seizures are detected. The issue with some of these devices are they can have high false alarm rates. You can imagine that certain movements, like chopping vegetables, for instance, can mimic the repetitive muscle activity of a convulsive seizure. So false alarm rates do happen, and most of these devices are recommended for use during sleep time. The issue of false alarms is particularly important in people with infrequent seizures, because in general, that means that when alarm goes off, it's most likely not a seizure. And there is a concern among some patients, their caregivers, and their clinicians, that they can have alarm fatigue. Other strategies have been promoted for seizure detection and alerting that don't have to be worn on the body, and that includes video-based seizure detection and alerting, using computer analysis of video streams to detect seizure-related motions in the bed or some other place. The problem is these seizures do have to have a considerable amount of movement to be accurately detected. Right now, these devices haven't been approved by regulatory bodies for seizure detection yet. but certainly a strategy. There are also several devices that are marketed primarily in Europe for detecting seizures in the bed using sensors that go under the mattress. And these use either audio or pressure sensors to detect movement in the mattress. Their performance when evaluated in the epilepsy monitoring unit hasn't been that great. They can miss seizures, especially for lighter kids and more subtle seizures. So something to consider that they may not work for everybody. And then, as Elizabeth alluded to, nocturnal monitoring using audio, such as baby monitors, can pick up some seizures if the caregiver is in another room, because many convulsive seizures are associated with very characteristic sounds like cries or groans that can be used to accurately detect seizures. And many families use simple baby monitors to detect if their loved one is having a convulsive seizure. So there are certainly devices that are now available and being developed for the use in seizure detection and alerting. They haven't been shown in studies to actually reduce SUDEP risk. Those studies would be difficult and complex to do. Most of these devices are primarily geared for detecting convulsive seizures, seizures with major movements, which is reasonable for their intended role of safety, because we know that convulsive seizures are the main seizure type that are associated with SUDEP. They primarily also work for nighttime seizures because either they're restricted to the use in one room in the bedroom, or their performance is such that they work best when the person is otherwise still. There are some other issues with wearable devices. For instance, if a wrist or armband device requires people to wear it, to charge it, to remember to put it on prior to bedtime. Video devices are, can be stymied if there's a blanket or a stuffed animal in the way, and you have limited just to the location where the blanket is pointed. Mattress sensors, again, limited to just the bed and may not work for younger or lighter children. Baby monitors require right now a level of vigilance because there's no built-in alarming system. So they have to, the families have to be sensitive enough to wake up to the sound of the seizures. There are some families that use other devices that are not intended for seizure detection, such as vital sign monitors that detect pulse or heart rate or oxygenation. But those sensors haven't been well studied for detecting dangerous seizures, and the same issues regarding wearing the sensors and making sure they're on all the time. Setting the appropriate thresholds apply here as well. So, in summary, this is what we know for SUDEP prevention. We know that there's no guaranteed strategy. So what we do is focus on risk reduction. We say that patients and caregivers should be informed about SUDEP early in the course of the treatment because it influences decision making throughout the therapeutic journey. So it reinforces the rationale for treatment, why you are prescribing medications to prevent and reduce the frequency of seizures. It's an opportunity to talk about the steps that need to be taken to reduce risk, including lifestyle factors that we discussed earlier. And then talking about SUDEP early in the course of treatment can provide realistic risk assessment to patients who are newly diagnosed with epilepsy, who will read about SUDEP on the internet, and it actually can relieve anxiety in people who may be at low risk, people who don't have convulsive seizures, or for whom seizures are under good control. And it's important that the clinicians, the patients, and caregivers work together to reduce seizure frequency. It's important that we come up with strategies to treat a sort of anticipated seizure exacerbations, seizure clusters, or preemptively treat situations where we know that seizures are more likely with rescue medications. And then talk about strategies for monitoring and reacting to seizures during nighttime, whether that's talking about bed sharing, room sharing, or the use of some of these devices. So now Elizabeth is going to talk about.
Sorry, I just had to unmute. I think we just wanted to take a moment to address that some of these preventative strategies or use of devices could be different when we're applying them to children and young and teens and young adults. So in kids, we recognize that some SUDEP risk reduction strategies could be actually easier. We have parental supervision that assists with medication adherence and lifestyle factors. And we know that kids live with their parents. And actually, as a child neurologist, I feel quite lucky that when I'm talking to families about SUDEP, we can talk about some of the strategies of using a strategy at night and making sure kids are getting their medications to actually reduce risk. But we also know that that pressure and that burden on parents and caregivers can be very significant and very intense. And we spend time talking to families about that. And that fear of SUDEP and other risks associated with epilepsy can really have a very significant impact on the development of independence in young people, in kids and teens and young adults. And that's something families really struggle with, all the way from young children trying to separate from sleeping with their parents, or parents try to separate with sleeping with their kids, right up to giving teens the independence they need so that they'll be able to kind of move forward with the self-care that they need moving forward as adults living with epilepsy. And to add to that, during the teen years, SUDEP risk factors can actually be amplified. I mean, I think Dan talked about kind of letting loose, right? So we know that when people are staying up late, not getting enough sleep, maybe missing their medications, those are really going to increase the risk of seizures and increase the risk of SUDEP. So we worry about adherence in teens and young adults. We worry about some of those lifestyle factors, including moving out of the family home. And actually, I don't know, Dan, your experience with this, but when we talk to young people about going off to school, college, or university, they struggle with, do I need a single room so that I have peace and quiet and I'm able to get the sleep I need to help to reduce my seizure risk? But if I have a single room, let's say in a residence or dormitory, then is there someone there to address my needs if I do have a seizure? So these are things that we just need to talk about with our young people that are going off and leaving the family home. And then there's always in young people a hesitance to acknowledge epilepsy and the inherent risks and possible limitations that brings up. So the best we can offer for this, I think, is open conversation. Thanks, Dan.
So in summary, just some take-home points from this talk. SUDEP affects about 1 in 1,000 people with epilepsy each year, regardless of age. The most important risk factor for SUDEP is frequent convulsive seizures. And the best way to reduce risk is to work with the healthcare team to reduce seizure frequency and seizure severity, and minimize those lifestyle factors, taking medication, as prescribed. And there are multiple seizure alerting devices that are currently available. They work pretty well for the detection of tonic-clonic seizures, but we don't know yet what the impact of these devices are on reducing SUDEP risk. So with that, we want to leave plenty of time to answer questions, and we'll stop sharing the slides. And so
Thank you very much indeed for a great presentation. We have about a little over 10 minutes left for questions, I think. And there are quite a few there. There's a difficult one about pregnancy from Tejal Mitchell, who's a neurologist in the UK with an interest in epilepsy. She says that the Embrace maternal death study, this is a study that looks at all maternal deaths in Britain every 3 years and analyzes them. And it's actually shown an increase in SUDEP in pregnant women. And so do the presenters feel that this increased risk is an independent increased risk of SUDEP in pregnancy? Or is it related to known risk factors such as an adherence to medication or seizure control, etc.? I don't know. I think perhaps, Dan, you might want to tackle that one.
Yeah, I mean, looking at that study and looking at the data, my impression is we know that about a third of pregnant women experience a worsening of their seizures during pregnancy, and that some of that may be due to changes in medication metabolism associated with pregnancy. Certain medicines, the clearance of certain medications like lamotrigine and levetiracetam increase, and so levels may drop and drop unpredictably, leading to worsening seizures. So that may be one consequence. The other may be that there are concerns certainly about the potential risks of medications to the developing fetus, and there may be some intentional misadherence as well. Women who are taking less medicine because they're concerned about the effects. So that's another opportunity to have that conversation prior to pregnancy to make sure that medication levels are monitored throughout the course of the pregnancy if they're on those types of medicines affected by pregnancy, and that any concerns about the risks of medicines are addressed before conception.
In fact, I mean, Penel has shown that if you really are proactive about managing patients, then the seizures frequency will not go up. So that's really important, everything you've addressed, Dan. Can I ask you this question, if that's okay, Elizabeth? I think it's a little bit difficult. Please elaborate on realistic risk assessment. This is from Sophie. How would a low risk be identified to you and how communicated beyond no tonic-clonic seizures? Are there any numbers and scales available? I'm not really sure any of the scales are that good, but perhaps you'd like to make a comment on that.
Yeah. And hi, Sophie, thanks for joining today. I think, so there is something, if you look it up, there is something called the SUDEP 7 inventory. And what this did really is take the risk factors that basically the ones I outlined, right, Lina, like the risk of GTCs and that, and kind of put them into an inventory. I don't think that is something that's used that much in clinical practice. Certainly not in my experience. Dan, can I get like a head shake one way or the other? No. So it's mainly been a research tool. I think that
and not a particularly validated research,
and not particularly
example.
Validated.
Yeah. Although the French one may be better.
Pointing that out, Lina. Yeah. Sorry. What's that?
There is a French one that is perhaps a bit better validated, but it doesn't necessarily translate to a risk you can hand over to a patient. You know, this is your risk. Yeah.
So so at this time, there isn't really a tool that I would use or a scale. There is a new website called preventingepilepsydeaths.org. And if you want, we can put that into the chat, which has information for both people living with epilepsy, but also for clinicians. And a large group of us actually worked on this together that I think can help to go through all the factors that could be influencing mortality risk, SUDEP risk, but also mortality risk in general in people with epilepsy. And you can use as a tool to help have those conversations with people. We consider virtually no one living with epilepsy has no risk of SUDEP, other than I have to say, I'm not familiar of anybody who's only had what we call absence seizures or primary generalized non-convulsive seizures. I've never heard of anybody dying of SUDEP of that, but we do know that those people do carry a risk of generalized tonic-clonic seizures. So even if you have that syndrome known childhood epilepsy, childhood absence epilepsy, or one of those absence epilepsy syndromes, I wouldn't consider the risk to be zero. So I think you really have to tailor the discussion to each person. I'm sorry, there's not a good, I can't rely on any numerical tool at this time. Dan, are you familiar with any tool to use right now?
Not apart from what you mentioned.
Not one that we can really feel.
It was and the French study. Sorry, I can't give you the reference offhand, but one of the factors they identified was whether people were able to warn others that they were about to have a seizure, which is an interesting new dimension. But let's go to another question. Dan, perhaps you could answer that. Rosie Rosas asks, what's the role about fluoxetine treatment, SSRIs, in preventing SUDEP?
Right.
So the background for this question is that in some animal models of SUDEP, treating with serotonin reuptake inhibitors or otherwise other modulators of the serotonin system, which is involved in both respiratory control as well as chemosensation, sensing the high CO2 levels, can reduce SUDEP in those models. It hasn't really been translated to people, and studies have looked at, for instance, whether people who have been prescribed SSRIs as part of treating depression or other reasons, and compared them to epilepsy patients who have not been prescribed SSRIs, and they appear to have similar mortality rates. So it may not be a universal preventative measure.
Thank you. And we have a question from Ehjele Isalar, who says, thank you for a wonderful presentation. And can you easily access seizure detection devices? Are they readily available? And also, I add another question to that. In how many countries will people be compensated for it? Or do they have to buy it privately?
So I'll speak to the situation in the U.S. because I'm not, I don't know what is other parts of the world, but in the U.S. there's only currently one FDA-approved device on the market, which is the Embrace, the Empatica Embrace 2. Right now, it is purchased privately, and there's a one-time cost as well as a subscription fee. In many cases, people can apply for insurance to reimburse for that device, but that's not always the case. I don't know what happens in Canada or in the UK.
Well, I know there are some other devices in Europe that have been cleared for use, but these clearing and approval is really, it's a safety. I see it as a safety check mark that the devices are safe for use, and they don't necessarily speak to, they speak to, their safe use in detecting generalized convulsive seizures, but they don't speak to their efficacy in reducing SUDEP risk.
Elizabeth, there's another question which I think you've partly answered in talking about absences. It says, what about the risk of SUDEP in refractory focal epilepsy with impaired awareness, implying, although Sammy doesn't actually say that.
That's a good question, Sammy. Thank you. I think that what I was talking about were absence seizures, which are generalized seizures with impaired awareness. When we talk about focal epilepsy with impaired awareness, if that was the only seizure type and people were not having full body shaking seizures or generalized convulsive seizures, then that would be, the risk would be considered to be lower. However, we know, don't we, that people with focal seizures with impaired awareness are at risk of having generalized seizures. Those seizures turn into bigger seizures, right? So we know that risk is present. So the risk would still be there, but it would be in the category. If you look up some of the tables that are available, it would be in the category of people who are not having generalized tonic-clonic seizures.
Yeah, I think
so the risk would be lower.
The Swedish case control study with 255 cases, only 4 out of the 255 had not had a history of
GTC,
tonic-clonic seizures. So that,
but of course, like we still hear of the cases, right, Lina, where they do have SUDEP, and it's quite possible in that case they've had a generalized tonic-clonic seizure, or they've had a SUDEP without a generalized tonic-clonic seizure.
Yeah. But it's, as you said, a much lower risk, isn't it? Yeah. Now there was another question, which is, could some of the more developing technologies help reduce risk? For example, MJ and SERAS, I don't know that, or the subcutaneous EEG, which are being studied. And David Thornton says he appreciates there are limited data on this at this time.
So these devices, for those who aren't aware, are continuous EEG recording devices. I think one of them records EEG from the ear, the other one from under the scalp over the bone. And right now, it really is about whether or not there are algorithms that can detect EEG changes associated with seizures fast enough to provide an alert that can run on these devices. And I'm not sure that is the case yet. The other issue is that not all seizures have behavioral expression. So you have seizures that are silent, and some people with epilepsy have many of those, and you may not want or need to be alerted for seizures that are clinically silent or even that are not convulsive. So an EEG in the absence of some sort of sensor for behavior may over-alert people. The other thing that I do want to mention, and the main limitation of devices is you need, and for alerting, is you need somebody on the other side of the device to close that loop, to provide that intervention. So if there's no caregiver around, whether somebody lives alone or their caregiver is out of town, it really doesn't matter if the seizure is detected if there's nobody there to provide aid after the seizure. We published an unfortunate case of a teen who had gotten one of these seizure devices, as detection devices, a week earlier, and his parents went out to dinner about 10 minutes away. And while out at dinner, they got an alert. By the time they made it home, the teen unfortunately had died. So the device worked, that just didn't, intervention wasn't delivered in time. So I think from a technological standpoint, I think we need to be thinking more about closed loop devices.
Okay, well, we're up to 2 o'clock, which is the time the webinar is due to end. I'd just like to thank everybody who's attended and contributed with the questions, and also our 2 excellent speakers. Thank you very much, Dan. Thank you very much, Elizabeth. And hopefully we'll have some more webinars, cover some of these topics in more detail if people are interested. Okay, bye for now. Thank you.